Welcome to this webinar today. I'm Dr. Bernard Filner. I'm in Rockville, Maryland at the present time, and today we're going to talk about two very common problems that practitioners will see, both if they see sports players and or runners. And certainly, if they have a general kind of practice, they're going to see a lot of these kinds of problems. And we want your feedback during our presentation. If you can ask any questions that are sort of not personalized to you, but might be interesting to the group as a whole, type it in the chat box on the right of your screen. And certainly, we would like to have any feedback, both positive or critical, either at the end of the webinar, or you can do that by email at the address that we'll give you at the end of the webinar. You can ask any personal questions that way in terms of any particular patients or problems you've had, either using the MLA30 or whether you're about to purchase one and would like some information about treating a particular problem that we haven't covered. Now, just to let you know what my experience is, so you know where I'm coming from during this webinar, is that I was a board-certified anesthesiologist for 19 years. I developed Meniere's disease and then had to stop working in operating rooms, and I've been in a single solo practice of pain medicine for 23, or actually it's almost 24 years now. Initially, Dr. Janet Travell helped me get started in this practice, and I worked with her for about 10 years. She came up and gave both positive and negative criticism of things that I needed to do, and invited me to lecture with her, as well as to participate in some of her teaching seminars. For the first 15 years of this practice, I had become very adept at doing trigger point injections, and I did over 250,000 of them. Indeed, I had many referrals just for that purpose. In the last 4 years, since I've had the availability of the MLA30 cold laser, I have dropped to an average of 50 or less per week, and I now only have, I think it's 3 patients now who get trigger point injections. At this point, I've inactivated more than about 120,000 trigger points individually with the low power laser. The one thing that's the most important thing for you to do when you're treating patients with chronic pain is to think outside the box and avoid the trap of pigeonholing patients, that as soon as they say a particular word or group of words, that you think only in terms of 1 or 2 particular diagnoses, and follow up with appropriate testing and treatments based on that pigeonholing. In particular, when you're dealing with myofascial pain, which is the overall content of these webinars and how to deal with it, I think you need to be very, very open about seeing patients' symptoms as signs of referred pain and or actual trigger point pain. It is different than you would expect. And frequently, when you see a pain pattern which is not the standard that you would expect, you should think that this could indeed be myofascial pain, and it most likely is. I would say probably 90 to 95% of all soft tissue pain is in fact myofascial pain, or at least involves myofascial pain to some degree. So it's really important that you try not to suddenly jump to conclusions when you're dealing with patients with chronic pain. Now let's get into this plantar fasciitis first. Besides the fact that it's one of the few words in the English language that has 2 eyes, together. It's an important cause of chronic pain, more often than not because it's a mistaken diagnosis. If it's a true plantar fasciitis, it's related to microtears of the plantar aponeurosis and results from and both causes further excessive pronation. So if a person excessively pronates, they can in fact develop a plantar fasciitis if they run or if they do certain sports, especially to excess. And then you'll find that they will actually pronate further as long as the pain of the plantar fasciitis is there. Now, when a patient comes in either with that diagnosis or you suspect that diagnosis, you have to think of myofascial pain, because more often than not, that's what it is. It's either trigger points, which will show you directly, which means they're active trigger points, or the pain is in the reference zones from trigger points elsewhere, or both. And we'll show you pictures of that so you can begin to think in those terms and treat these patients better than the podiatrists who will simply try to use an orthotic approach, which usually doesn't work, and follow this with cortisone injections, which also usually don't work. In order to make the diagnosis, you have to palpate the plantar fascia, primarily at the mid-arch, as well as the attachment on the calcaneus at the heel. And you also should evaluate the patient for excessive pronation, since this predisposes the patient to this problem. If you think it might be myofascial pain or this diagnosis is not solid, look for trigger points in the following muscles in this order: the gastrocnemius, the soleus, the flexor digitorum longus, the tibialis posterior, the quadratus plantae, and the toe flexors, which are the abductor hallucis, the flexor digitorum brevis, and the AB, as in boy, ductor digiti minimi, which we will now show you in a few slides. Just to refresh your memory or to bring it to the fore if you haven't seen this before, when a muscle is electrically silent at rest, meaning the muscle may be just either slightly tense or very tense, but it is not actively in spasm, the trigger point itself is electrically active. And if you put an insulated EMG needle into a muscle that's at rest, you see no activity, and as the needle gets into the trigger point, it begins to register that activity. The trigger point is a zone of what we call dysfunctional end plates that resulted in mini contracture, which is palpated as a taut band. This is David Simon's theory and has probably the most adherence as the most likely explanation as to how a trigger point is formed. As to what causes the dysfunctional end plates, at this point there may be some theories, but we don't know specifically what the final train of events is. Once this taut band is formed and you have a decrease in the circulation because this taut band can compress some of the very small capillaries and arterioles, there's an alphabet soup of compounds such as CGRP, substance P, etc., that are released and sensitize the nociceptors, the small C fibers that are in that area, and may at this point cause the pain of an active trigger point. As to what causes the pain in the reference zone, there is no specific theory at this point, although my own feeling is that it is certainly carried in the sympathetic nervous system, and how that's translated into pain I don't know at this point. One thing to remember when you look at people's reports, etc., you'll often see a phrase that there's no spasm in X muscle. That does not mean that there's no trigger points in that muscle, because the muscle could still be tight and not perceived on palpation to be in spasm. There's a clear difference between the two, and unfortunately the best and really the only way to really solidify that in your mind is to demonstrate it, and we can't do that over the web at this point. In terms of locating and palpating trigger points, you can either locate them by this sort of plucking type of palpation that plucks the trigger point, and we'll usually see a twitch response in that muscle, or so-called pincer palpation in a muscle such as the latissimus dorsi, where you'll grab part of the muscle and then run your hand along this line that will then do the typical palpation and looking for a twitch response as your finger goes over and sort of strums the trigger point. Now, this is the picture of the plantar fascia, where you usually find sensitivity when you have these micro tears is in the middle of the arch here, or even more commonly at the tendon. I guess it shouldn't be considered a tendon, it's just the calcaneal attachment of the plantar fascia. And this is one of the circumstances where if this is here long enough and is irritated enough, you'll probably get the growth of bone spurs on the calcaneus. Those are not the cause of the pain. The cause of the pain is the inflammation in the plantar fascia in this case. Now, if you suspect or you don't find the typical signs and symptoms of plantar fasciitis, then you have to look for trigger points and reference zone pain. As you can see, this trigger point in the gastrocnemius refers precisely to the place where the plantar fascia will have the greatest amount of tenderness. So this is probably the most common cause of the symptom, which is interpreted as plantar fasciitis. Now, the soleus, which is the deeper muscle, will frequently give you the heel pain that you'll see with the attachment of the plantar fascia here. And if most of the pain is actually on the heel bone itself, on the calcaneus here, you probably would suspect the soleus muscle first. And now the flexor digitorum longus has a trigger point right up here on the medial portion of the lower leg, and refers down into this area a little bit more laterally than you might usually feel the tenderness from plantar fasciitis. Tibialis posterior is usually palpated, the trigger point's usually palpated a little